Okay, so I think we are ready to start. Again, welcome to everyone. I'm Mariangela Pellegrini. I'm the Educational and Patient Manager for the ERN-EuroBloodNet, so the European Reference Network on Rare Hematological Disease. So I'm really pleased to welcome all of you, not just on behalf of the ERN, but also on behalf of the European Haemophilia Consortium, because indeed this program, named Topic on Focus from Willebrand Disease for Patients, Organization and Healthcare Professional, has been co-organized by the ERN and European Haemophilia Consortium that is represented by our ePAG Baiba Ziemele. And this indeed educational program has been created in partnership with EURORDIS-Rare Diseases Europe and has been supported by the member of the scientific committee, Professor Sophie Susen, Professor Jeroen Eikenboom, and Professor Flora Peyvandi. So as you may know, as you can guess, we are going to talk about the von Willebrand disease in a very broad way. And for explaining that, I will pass the floor to my colleague Daria Camilli from the EHC, so she can explain to us the pedagogical objective and all the idea and the support from the patient consortium behind. Thank you very much, Daria.
Thank you, Mariangela. I'm Daria Camilli, Education and Communication Manager at the European Haemophilia Consortium. And first of all, before I start, I want to thank on behalf of the EHC, the ERN-EuroBloodNet for cooperation and for creating a platform for such truly unique projects like this one. Thank you very much. And now a few words about the EHC. So European Haemophilia Consortium, or the EHC, is an international non-profit organization representing 48 national patients' organizations for people with rare bleeding disorders from 27 member states of the European Union and most member states of the Council of Europe. We represent approximately 90,000 people living with rare bleeding conditions such as hemophilia, von Willebrand disease, and other rare bleeding disorders across Europe. However, experts estimate that many more live with an undiagnosed rare bleeding disorders. And among all of them, von Willebrand is the most common bleeding disorder, affecting up to 1% of the general population, although it is often neglected and overshadowed by hemophilia. This program aims to distinguish von Willebrand disease from hemophilia and focuses on the particularities of this bleeding disorder. This is especially important for us that we launched this program today when at the European level we celebrate von Willebrand Disease Awareness Day on the birthday of Eric Adolph von Willebrand, who first discovered and described this condition 98 years ago. Today, the EHC von Willebrand Disease Committee has unveiled the European identity and a logo and a slogan, making the invisible visible. And I truly believe this can also serve as a slogan for our program too, because during this program, we will discuss very topical areas related to von Willebrand disease among patients and healthcare professionals, and will give visibility to the challenges of those living with this rare disease, including quality of life, access to treatment and care, medical services available in Europe, diagnosis, treatment options, and the overall patient journey through life.
Thank you very much, Daria, for recalling this important objective of this program that indeed consists of 13 sessions, because we really want to tackle from A to Z all the topical areas for von Willebrand disease, including also quality of life, emotional trauma, female topics. So it's really a comprehensive one. Before arriving to today's lecture, I would like to share with you some more information. So for you to know, this program is accredited, so you can request one continuing medical education point to the European body of accreditation in hematology. How to request the credit? You just need to pay attention in writing properly your name and surname during description and here in the platform, because then we track your presence and we will contact you providing all the information for going to this accreditation platform and request the credit for each session. Said so, I said 13 webinar, one per month on Thursday at the same time slot. And at every webinar, we will have a duo of a patient representative and a care professional, or a trio, because for some session we will have also nurses. And also, coming back to the home rules, I was forgetting one important point. Sorry. This program is registered. So if you don't feel comfortable with that, you can switch off your camera, change the name in the platform, or simply notify it to me or to Daria, and we will take care of it. And also, your microphone are muted, but at the end of the presentation, we will have the possibility to having a debate and Q&A session with the speakers. So you will have both the possibility of writing your question at any moment in the chat, or at the end of the presentation, if you prefer to express yourself orally, you can unmute yourself and take the floor. Then finally, now it's true, we arrive at today's lecture. So we decided together with all the patient representative and committee to launch this program with one important matter, that is von Willebrand disease is not hemophilia. And today we are going to understand why and how it's not hemophilia. And with us, we have Professor Jeroen Eikenboom. So sorry for mispronounce your name every time. So from Leiden University Medical Center and our ePAG Baiba Ziemele. So I have the pleasure to present to you Professor Eikenboom, who he's Professor of Internal Medicine and Hemostasis and Thrombosis since 2011 in Netherlands at the Erasmus University Rotterdam. His clinic work is focused on bleeding disorder, thrombophilia, and vascular medicine, and his research focused on bleeding disorder, especially von Willebrand disease.
And with great pleasure, I present to you Baiba Ziemele, EHC von Willebrand Disease Committee member since its foundation in 2020 and the patient representative for this webinar. Baiba, the floor is yours.
Thank you very much. I'm so excited that I even don't know where to start. I want to say a big thank you to EHC and also ERN, because this is like one in a lifetime opportunity to start speaking about von Willebrand's. As you probably know, we got global guidelines for von Willebrand diagnosis and treatment approximately 3 years ago. But in the committee, we still hear a lot of heartbreaking stories from patients around Europe and beyond it. And therefore, we decided that we have to start from a blank page. We have to go together with professionals. So we created this fantastic program in which you will learn very many good things. You see, the problem, like I am also a patient. I was born with von Willebrand's, and it took me almost 40 years to find out my type. And I'm still trying to get the appropriate treatment, which is not available in my country. And with this story, it embodies the stories of many people living with von Willebrand disease in Europe, because every time when we go to the doctor, they say that this is not hemophilia. And there are two sides of this. One is that they don't know how to treat it. Usually they say it's too complex, we don't have treatment for that, or maybe it's not severe enough. And then on the other side, hemophilia is a concept that many of you know very well, and it has been around for many years, and it has like very good awareness in public. And I know that in Latvia, 50% of people know what is at least they say they know what is hemophilia, but only 1 in 10 says that they know von Willebrand's, which is probably not true, because we know that most people say that this is too complex to understand. And to break this perception, we have decided that we will go and start teaching you. So today we have agenda. We have made the agenda from following things. First, the professor will explain you coagulation cascade, how it actually works. Then he will talk about von Willebrand disease and why it is different from other bleeding disorders. He will briefly touch also different types of von Willebrand disease, because this is very important for finding the right treatment for patients, and also to discuss symptoms, because you know that sometimes even like not only us as patients, but also doctors do confuse what is and what is not severe symptom, what is mild symptom, and how they should be treated. And then he will also talk about the phenotype, how all these symptoms together make you as a person a different patient, about the guidelines on diagnosis and management, and how to get the diagnosis correctly, and when and what tests to take, and also briefly about the treatment options. But I invite you to come to our webinars also in the future, because we will go in more details in each of the subjects in other cases as well. So I will give floor to our professor, who has kindly agreed to start this explaining this very complex topic, and we will answer your questions afterwards. Thank you.
Okay, thank you. Then I will take over the floor. First, regarding conflicts of interest, I sometimes receive research funding from CSL Behring, but it does not have an impact on this presentation. So actually, what I will do is first explain how coagulation actually works. And this is, of course, a complex matter. And therefore, I try to simplify this in a way that it's also for patients readily to understand. So it would be very easy if the hemostasis system would be just like a simple switch. So when you have a wound, you need coagulation, and that you put on the switch and it starts clotting. That would be easy, and at the time when it's done, you switch off this device. But in general, in biology, it's much more complicated, and actually also it's much more complicated with regard to coagulation, because the system looks more like a machine like this, with many dials that can be turned up or down, and everyone has a different biological and genetic background. So all individuals may have these switches and dials in a slightly different way, and that makes why a person clots better than another person. And in some cases, this may lead to bleeding, and in other cases, it may even lead to thrombosis. It's just how this balance of dials is set. And today we are, of course, focusing on von Willebrand disease, and you should consider that von Willebrand factor then is only one of the many dials that makes the whole set of hemostasis. But we are also talking about factor VIII, and factor VIII and von Willebrand factor actually are closely linked together in the circulation. So those two proteins are actually together in a complex. So today we will be talking about this complex of von Willebrand factor and factor VIII, and we will zoom into how they actually influence the entire hemostasis system. But before I go into detail on von Willebrand factor and factor VIII, I will go a little bit on the entire system with all those dials. So in fact, when does the hemostasis system start? That's actually when there is a damage to the vessel wall. So as long as the vessel wall is intact, then the blood is remaining fluid. Only upon damage to the vessel wall, this can be surgery or trauma, or sometimes also severe bacterial infections, they may damage the vessel wall. And as soon as the vessel wall is damaged, this leads to a reflex of the body by constriction of the vessel. So you can imagine if you have a wound, it's very advantageous that at that point the vessels constrict to reduce the loss of blood, because the vasoconstriction, so narrowing of the blood vessel, reduces the blood flow. But that's not enough. The blood should also become clotted, not just only a slower flow of blood, it should really start to clot. And how does that happen? So when the vessel is damaged, below, underneath the lining of the vessel, there is collagen. So that's tissue that is all over the place in your body, but it's shielded from the circulation by the cells that actually line the vessels, and that are endothelial cells, and they protect the contact between the blood and the collagen. But upon damage of the vessel wall, this collagen protein comes into contact with the blood, and immediately the cells in the blood, the tiny platelets that are circulating in the blood, will start sticking to the collagen, and they also start to stick together, and that makes the platelet plug. So actually the platelet plug closes the hole in the vessel wall. And there is also some interaction, because the platelet plug that is being formed has also a further stimulation for this vasoconstriction. All this together, so the narrowing of the blood vessels and closing the hole in the blood vessel by the platelet plug, that is often referred to as the primary hemostasis. So primary hemostasis, the function of that is closing the hole, the vessel actually. Then there is another system, because if you would only have this system, the bleeding stops, but later on the bleeding may start again, because the platelet plug will start falling apart again after a few hours. So you need a system to really make this a firm platelet plug that will not dissolve again. And for that, we actually need a system, what we call actually blood coagulation. So that is the cascade of reactions that lead to the formation of fibrin. And fibrin is a network of protein fibers that actually strengthens this platelet plug. And to start this system, you need a protein that is called tissue factor. And the name already says it, tissue factor is not in the blood, it's a protein that's in the tissues. So again, when there is damage of the vessel wall, the blood from the bloodstream may come into contact with the tissue factor, and then the tissue factor actually is the starting point or the initiation of the formation of this fibrin. Again, there is some interconnection between these systems, but this formation of the fibrin is what we call secondary hemostasis. So primary hemostasis makes sure that the hole in the vessel is closed, and the secondary hemostasis makes sure that the platelet plug that closes the hole is becoming a firm platelet plug that will not fall apart again after a few hours. Altogether, this entire system, that is what we call hemostasis. So actually hemostasis means literally that the blood comes to a standstill. It really stops this flow of blood over there. And then finally, after the blood has come to stasis, at some point the wound needs to be repaired again by the body. And in that stage, you also need fibrinolysis, and fibrinolysis is the system that breaks down the clot again. So after some time, the clot needs to be removed, and that is what we call fibrinolysis. So this is actually the entire system in a more general overview. When we are talking about Willebrand factor, you should realize that Willebrand factor plays an important role in this platelet plug formation, and we go into details later on. And factor 8 plays an important role in this formation of the fibrin. So they have a different function in the hemostasis mechanism, but as they are circulating together as a complex in the circulation, defects in fulveillance factor may also have effects on factor VIII, but we will see that later on in this presentation. So what is then fulveillance disease? And to visualize that, you could consider the platelets, so the cells in the blood that needs to form the platelet plugs, if we resemble that by bricks. Then you can consider fulveillance factor actually the mortar or the cement that is necessary to make the bricks come together, to make the platelets stick together. So if you have enough platelets that function correctly, and you have enough and good fulveillance factor, then these together make sure that you will build a brick that is actually resembling the platelet plug. However, if you have something wrong with the cement, you have not enough, or it's of bad quality, so you have not enough fulveillance factor, too low quantity, or too low quality of the fulveillance factor, this may lead to a bad wall. So you will not be able to form a platelet plug that is able to really close the hole in the vessel, and you see there's still a hole present over here. So this is actually what more or less resembles fulveillance disease. So to show that in a more scientific picture, so this is actually a cartoon that resembles actually the blood vessel. Here you see the blood flow. The blood is flowing from left to right in this picture. Here you have the endothelial cells, so that are the cells that are lining the inner side of the vessel. So the vessel wall on the inside has endothelial cells, and actually they should form a continuous layer. But at some point, when there is a vessel damage, this endothelial layer may be interrupted. So at this point, there is no endothelial layer anymore. But as I explained, you have collagen, so that is a protein that is underneath the endothelium. So when the endothelial layer is disrupted, the collagen, these fibers, gets into contact with the blood. And in the blood, what is represented over here, we see the platelets, so the cells that needs to clot together to form the platelet plug, and we see fulveillance factor, the protein that is circulating in the blood. Normally, the fulveillance factor is coiled together and it's in an inactive form in the blood, so that it does not start to spontaneously bind to the platelets. So it's in an inactive form in the blood, and also the platelets are not active. So these are inactive platelets actually. When, however, the blood flows over this collagen surface, the fulveillance factor wants to stick to the collagen, and when it does that, the fulveillance factor more or less unfurls, it unrolls, so it gets in an open conformation. And then the sites in fulveillance factor that are able to bind to receptors on the platelets, so there are all kinds of things on the surface of the platelets, and that is what we call receptors, then this receptor can bind to the collagen. And the collagen in that way, so the fulveillance factor, and in that way, fulveillance factor connects to the collagen over here and here to the platelet. So in that way, the platelet is getting stuck on the surface of the collagen. When that happens, the platelets get activated and they also start to stick together also via fulveillance factor. So you have platelets sticking to collagen via the fulveillance factor, but also platelets sticking together. So this together makes that there is a platelet plug being formed, like a brick wall that closes the hole in the vessel. So that's actually what fulveillance factor does. But what does factor VIII do? So for that, I also made a graphical representation. So actually, factor VIII plays a role in what we call the coagulation cascade. And the coagulation cascade contains a lot of coagulation factors. They are very complicated in this cartoon, but there are many coagulation factors. And you can imagine the coagulation factors like these domino blocks. So if you take out one block like factor 8, if you would remove that, then the domino will not fall. So it stops. So if you go into this complex coagulation cascade, you need all these factors to come from the tissue factor. That is what I called the starting point of the coagulation. So if I go back one slide, so the vessel wall, when there is injury, there is tissue factor that actually starts the coagulation cascade. If this starts, but when you remove one of these factors in this entire system, you will have an interruption of these domino blocks that are falling. And what we're talking about now, so we were focusing on factor 8. It's an important factor in this entire system. So if you lack factor 8, you will not have this system working very well. And actually, when you miss factor 8, then you have what we call hemophilia A. But you see at the same position, there's also factor 9. That is one of the other coagulation factors. And if you miss factor 9, that is what we call hemophilia B. All the other factors in this system may also be lacking, but we are not going to focus on that in this presentation. So we only focus actually on factor 8 for now, because factor 8 may cause hemophilia A, whereas we are also talking about Willebrand factor that causes Willebrand disease. So in the circulation, factor 8 is bound in complex to Willebrand factor, and defects in Willebrand factor may, as a consequence of that complex formation, also have an effect on factor 8. So if I try to put in a table the differences between Willebrand disease and hemophilia A. So first, if we consider the difference between males and females, Willebrand disease is actually equally present in males and females. The gene that codes for Willebrand factor is what we call an autosomal gene. So it's coded on chromosome 12, and actually everyone has 2 copies of the gene for Willebrand factor. So males and females both have 2 copies of the gene, and depending on the type of Willebrand disease, either 1 or 2 of the copies of the genes may be abnormal, but there is no difference or no influence on the sex on the distribution of those abnormal genes. So actually males and females are equally affected. However, in hemophilia, the gene for factor 8 is coded on the X chromosome. That's actually the female chromosome versus the Y chromosome that is specifically for only present in males. So when you have an abnormality in the factor 8 gene, which is coded on the X chromosomes, males only have 1 copy of this gene. So they will always have, when they carry the abnormal gene, they will always have the disease. Females have 2 copies of the gene. So if they carry the abnormal factor 8 gene, they still have another copy of the normal factor 8 because they have 2 copies of the X chromosome. And it depends in the females how this actually is expressed, and their factor 8 may vary. So their factor 8 may be completely normal, and even if they have the factor 8 gene and the factor 8 level is high, they are carrying the disease but are not experiencing symptoms themselves. But when the factor 8 level is lower, and that's the case in many of the carriers of the factor 8 gene, if the factor 8 level is below 40%, they have, like the males, also have the symptoms of hemophilia. So in the past, we always said, well, they are just carriers, but no, when they have 1 copy of the gene, they are all carriers and may pass the gene on. But when their factor 8 levels are below 40%, they are also to be considered actually hemophilia patients. But that's the main difference between Willebrand disease and hemophilia A. In Willebrand disease, if you have the abnormal gene, then you will have the disease. And in hemophilia, it depends a little bit on your factor 8 level, whether the disease is really being expressed in the person. The inheritance, I already mentioned that. So in fulminant disease, this is autosomal dominant. That means that if you have one abnormal gene, you will have the disease. But in some rare conditions of fulminant disease, it's recessive, so you need to have it inherited from both your parents. And in hemophilia, it's X-linked recessive, so it means it's linked to the X chromosome. And if you have this X chromosome, and you in females, it depends only on how much factor VIII you have, whether you have the disease. But if you are a man, you immediately have the disease. Well, what does it do in hemostasis? Well, as I explained in fulminant disease, the major defect is in fulminant factor, and therefore the primary hemostasis is disrupted, whereas in hemophilia A, the secondary hemostasis is interrupted. However, if in fulminant disease your defect in fulminant factor is so low that also your factor VIII gets low, then you may have additional to your primary hemostasis defect also a secondary hemostasis defect. But when you have hemophilia A, you only have a defect in the secondary hemostasis and will not have a defect in the primary hemostasis. There's also a difference between symptoms. So in fulminant disease, many of the symptoms have to do with having bruises or bleeding from the mucous membranes, or bleeding after you have had an incident, an accident or surgery. But there may be also some bleeding from the intestines, or rarely you may have joint bleeding. Whereas in hemophilia, the focus is mainly on bleeding in joints and muscles. Treatment. In fulminant disease, usually we treat when there is a bleeding or when we know that there is surgery coming, so we treat prophylactically at the time of surgery. And only rarely the patients will have continuous long-term prophylactic treatment. Whereas in hemophilia, many of the severe patients will have definitely long-term prophylaxis. And other patients that have milder hemophilia will only be treated on demand. So there are clear differences between fulminant disease and hemophilia. So now we focus a little bit more on the fulminant factor. So and to explain how you have different types of fulminant factor. So actually, fulminant factor is synthesized and made in the body in the endothelial cells, so the cells that are lining the vessel, but is also produced in the platelets, so the cells that clump together to form a platelet plaque. But you should realize the following. Fulminant factor is produced in the endothelial cells. It has many different domains, but it's not relevant for you now. But this protein actually forms together with one other protein a duplex, so actually what we call a dimer. So two proteins are linked together during their synthesis in the cell. When they move on in the cell to another stage in their synthesis, those duplexes of two fulminant proteins even connect together, so you form a very large protein of many of those subunits together to one very long protein. A protein that is able to at one point bind to collagen and at the other end of the protein bind to platelets. So it can really make connections. And it's a very, very big protein. And you should realize, and that's important to understand, that if you make the protein in your endothelial cells, if you have one of your fulminant genes that is abnormal, so you can imagine that some of those subunits are abnormal and others are normal. But as a consequence of that, only if you have the half of your subunits abnormal, the entire complex of this protein gets abnormal. So that's how it is the case that if you have only one gene defect, in fact, this may result in a protein that's completely having a defect. That's indicated over here. So if you consider this large protein, if you have normal subunits and abnormal subunits coming together, you can imagine that now, even though you have 50% normal fulminant factor and 50% abnormal fulminant factor, in fact, you will have a large complex that includes both subunits, and this complex will now be abnormal. Which types do you have for Willebrand disease? So in the majority of cases, 75% of cases have what we call type 1 for Willebrand disease. Actually, they have a reduction of the protein, but the protein itself is still functioning normally. You only have less of it. Usually, this is rather mild form of the disease. In type 2 for Willebrand disease, around 20% of all the patients, you will have abnormal or structurally or functionally abnormal Willebrand factor. And usually this is more severe than type 1 for Willebrand disease. And in type 3, that's a rare form of the disease, less than 5% of all the patients. And that's characterized by the fact that there is no Willebrand factor at all. And you can imagine, as I explained, that Willebrand factor and factor VIII circulate in the blood as a complex. If you have no Willebrand factor anymore, factor VIII cannot bind to Willebrand factor. And when factor VIII is on itself in the circulation, it is removed from the circulation very fast. So if you have no Willebrand factor, also your factor VIII may drop even below 10% of the normal. So then you will have not only a defect in the platelet plug formation, but you will also have very low factor VIII levels, and you will also have a defect in the secondary hemostasis. And this is considered a very severe form of the disease. We can visualize this. So this very large protein containing many subunits circulates in blood in different sizes. So this is normal plasma of a normal patient, and you will have different sizes of the protein. Actually, this resembles if you have only 2 subunits together. This is if you have 2 of those diamonds together, forming 4 subunits, 6 subunits, 8, 10, 12, and it goes on to very, very large proteins, depending on how many of the subunits are together. In type 1 for Willebrand disease, you will have all these normal subunits together, only you have a little bit less of this concentration. But in the forms of type 2, there are many different types too. You will lack a major part of these large multimers. So there's a structural defect, and you can imagine the largest ones are the ones that have the most activity for platelet plug formation. And in type 3, you will not have any multimers anymore because you don't have any protein actually. So this slide, I'm going over this because it's very complicated, but there are many subtypes of the disease and they all have their different inheritance pattern, but in later presentations, focusing specifically on the genetic defects and the subtypes of Willebrand disease. So in the later presentations, this will be tackled in more detail. And that also accounts for this because we know now where the genetic mutations are for most of the subtypes of Willebrand disease, and all these types and gene defects may have different influences on the formation of those multimeric complexes. But again, that will be tackled in later presentations that go into detail in this topic. I will now move on to focus a little bit on the type of the bleeding symptoms in Willebrand disease. So what you see in this slide, this is a graphic representation of the symptoms. Epistaxis, so bleeding from your nose, and the top bar indicates how frequent that occurs in individuals without Willebrand disease. The yellow one, the light one, in type 1 Willebrand disease, this one in type 2, and the darkest color is in type 3. And you see that from type 1 to type 2 to type 3, the symptoms usually become more severe because type 1 is the mildest form of the disease, type 2 is a little bit more severe, and type 3 is the most severe form of the disease. Cutaneous bleedings like bruises or minor cuts like this happens in mostly all Willebrand disease patients. Bleeding from the intestines is not that frequent, but in type 2 and type 3, this may even occur in 20% of the patients. Then, when we start extracting teeth, this is often a major challenge for Willebrand disease patients, and many of the patients experience problems with that. Also surgery, and then here again, menorrhagia is a very frequent problem in women. So menorrhagia, but also postpartum hemorrhage. So it's a wound in the uterus, and it's a mucous membrane in the uterus that bleeds, and this is an often experienced problem, not only in type 3, but even also in the milder forms of Willebrand disease in type 1. You will have many women having complaints of, and you see this over 80 to 90% of women really experience problems with menorrhagia. If we then move to the more severe bleeding, muscle hematoma and joint bleeds, that occurs frequently in type 3, and that's because they have so low factor VIII levels. So they experience the symptoms, muscle bleeds and joint bleeds, that is usually seen in hemophilia, but in type 3, because of the low factor VIII, they also experience frequently these severe bleedings. That's indicated over here. Then I will move, say something about the differences in how to diagnose for Willebrand disease. Well, it first starts with bleeding symptoms, either bleeding symptoms of you as a person or as a in a family. So even when you do the diagnosis in children, it could be that the child himself did not have bleeding yet, but it could be very clear from the family history that for Willebrand disease is in the family, and then it could be that even without symptoms, you may sometimes make the diagnosis based on the fact that there is a family history. But apart from the symptoms, you need laboratory testing. And without going into too much detail, what we can test is the Willebrand factor level, so how many of the protein is actually present in the blood. That's what we call the Willebrand factor antigen, how much protein is there. Or we look at the function of Willebrand factor, and we have different tests for testing the function. And also that will be in a later presentation, but you can test how good Willebrand factor is able to bind between platelets and collagen. So how much of the protein is there and what's the function of the protein? And we also measure factor VIII activity to see how low factor VIII is in a Willebrand disease patient, because the more severe Willebrand factor defects may lead also to defects in the level of factor VIII activity. And with the combination of all these tests, you can, and this is just a diagram, you can pinpoint which type of Willebrand disease is present based on how much of the protein do you have, how much of the activity do you have, or do you have specific defects in any of these functional aspects. So you will need a wide set of laboratory tests, which specific or usually can only be done in specialized centers with their laboratories. So usually in a general hospital, it's not possible to have all these tests done. They will refer the test then to another laboratory. Then some short notes on treatment. So treatment of Willebrand disease is often, as I already indicated, on demand. That means the treatment is given at the time that there is a bleeding, just to stop or control the bleeding. That may be at the clinic, but sometimes this can also be done by self-treatment at home. Then we have prophylactic treatment. Then you have the intention to prevent the bleeding. And that can be either incidentally, when there is a planned surgery or another intervention necessary, you can give treatment before and sometimes also after the surgery to prevent or minimize the bleeding problems. But in some cases, patients may have regularly spontaneous bleeding, like gastrointestinal bleeding or joint bleeding, especially in type 3, that may require long-term prophylaxis. That means that you will administer treatment a few times a week for a long period of time to prevent these bleedings. Well, what type of treatment do we have? We have specific measures that really are focused on the Willebrand disease specifically. And there we have DDAVP, fulminant factor concentrates, and I will go over all these aspects. So first, DDAVP. What is DDAVP? It's also known as desmopressin, and that's a medication that actually induces the secretion of your own stores of fulminant factor. So in the endothelial cells, fulminant factor is stored, and if you give this medication, fulminant factor, and also factor VIII, which is bound to fulminant factor, that will rise in the circulation 2 to 4 times your basal level. So if you have, let's say, 25% of fulminant factor in your circulation, this may go up to 75% after treatment with desmopressin. The peak of the after treatment is 1 hour after the infusion of the or administration of this medication, and then it may last for several hours. You can administer this drug intravenously via an infusion or subcutaneously, or there's also an administration intranasally. So you can use this for home treatment. The point with this medication is that the response, how good you respond to this treatment, is variable. Not every patient responds as good. So usually we advise a test infusion or test treatment to know how good a person will respond to this. The treatment is usually effective in type 1 because you still have fulminant factor, and the fulminant factor that you have is actually functionally normal. But depending a little bit on how low your fulminant factor level is in type 1, it may have a good or very good rise after DDAVP. In the type 2 fulminant disease with functional defects of the protein, it is usually not effective because the protein may get out of the cell, but what gets into the circulation still is not functional. And it depends a little bit on the severity of your specific type, whether it may be applicable to use desmopressin for minor bleeds, but you really need to test it to know how good you rise and how good the activity of fulminant factor will rise. Sometimes for minor bleeds it can be enough, but for more severe bleeds it usually is not effective enough. In type 3 it will not work because you don't have fulminant factor, so you cannot release any fulminant factor to the circulation. And if you have the rare type of type 2b fulminant disease, actually it's contraindicated because it may lead to a drop in your platelet count. So we usually do not give it to type 2b. You also should realize it releases your store of fulminant factor, so it will take time to replenish your fulminant factor store. So if you repeat the administration, the effect becomes less after the second or third administration. And you should take care, you may get low sodium in your serum, so low salt levels in your blood, so you will need a water restriction when you use this medication. But it's a rather cheap and for many patients useful medication, but not for everyone. Then if desmopressin is not effective enough, you can always use fulminant factor, whether or not it could be sometimes in complex with factor VIII. Actually, then you administer fulminant factor from outside the body with an infusion inside the body. And this can either be purified from plasma, or it can be made recombinantly. And there are many medications in the market, many different brands of fulminant factor concentrates, and they differ regarding how much factor VIII is in there. So, for instance, in Hemate-P, there's 2.4 more fulminant factor to factor VIII, but there is still factor VIII, whereas in others, like the recombinant product Peyvandi, there are only traces of factor VIII, so it's really purely fulminant factor. So it depends with which product you are treated, whether or not you also need or may require sometimes additional factor VIII treatment. So here's just to illustrate, in a type 3 patient, if you only infuse fulminant factor concentrate, so in green and red you will see the antigen and the activity of fulminant factor, it will rise immediately because you infuse the protein. But in a type 3 patient, you do not have your own factor VIII, but because now that you administer fulminant factor, the own factor VIII of the patient will start rising because it starts binding to the fulminant factor that's being infused in the patient, and after some time you will have also a rise in factor VIII level. Then we have more general measures for the treatment. So if you have a clot formed, if you then give a drug that prevents the breakdown of the clot, that may support actually the hemostasis in the patient. So it's not specifically focused to fulminant factor, but it's an additional treatment that may support the hemostasis, and especially when you have bleeding from mucous membranes, tranexamic acid or aminocaproic acid. These are both antifibrinolytics that may support actually the hemostasis. And actually what it does in the body, there are two proteins, plasminogen and plasminogen activator, that both bind to fibrin, and then the fibrin is cut together, cut so that the fibrin breaks down again. And actually the antifibrinolytic drug more or less mimics one of the side branches of fibrin, and it gets stuck into the plasminogen. The plasminogen cannot bind to the fibrin, and the fibrin will not be broken down. So actually it prevents the breakdown of the clots and thereby supports hemostasis. And finally, often when the problem has to do with heavy menstrual bleeding, just regulating the menses using oral contraceptive pill may minimize or reduce the bleeding due to menorrhagia. So it's nothing to do with Willebrand disease, but it may support the treatment of the disease. So now I have explained to you all the mechanisms of hemostasis, explained the difference between Willebrand disease and hemophilia, the difference between fulminant factor and factor VIII, and focused a little bit on what is necessary to make the diagnosis and the type of symptoms. A few years ago, it was already mentioned by Baiba in the introduction, there were a few guidelines published. One guideline was a collaboration with the American Society of Hematology, the ISTH, the NHF, and the World Federation of Hemophilia. So a major collaboration of all the scientific communities involved in Willebrand disease. And one of the guidelines was focused specifically on the diagnosis, and one guideline was specifically focused on the management. And these guidelines are now being used in all over the hemophilia and Willebrand disease treatment centers and guide their management of the patients. So to summarize what we have done in this first general presentation, we actually defined the disease and the clinical presentation. So Willebrand disease is a bleeding disorder due to an inherited defect in fulminant factor. It results in a defect in the primary hemostasis due to an abnormal formation of the platelet plug. It may lead to spontaneous bleeding or bleeding after trauma and surgery. A major problem actually for women is the heavy menstrual bleeding. It's one of the major problems we encounter in clinic. And the treatment is focused on treating with DDAVP to release the own stores of fulminant factor that you still have. So you use your own fulminant factor for the treatment actually, or if that doesn't work, you can infuse fulminant factor concentrate with the support of drugs that prevent the breakdown of the bleeding. So that's basically what we did in this presentation. And I think we can now move on to questions. And for the questions, I think I will move back to the presenter and stop sharing so that we can see each other again. So with that,
Thank you.
I will give the floor back to Mariangela.
Thank you very much, Professor Eikenboom, and also to Baiba Ziemele. Thank you so much. It has been so clear and comprehensive. And I can see we have already a first question. As said before, you can raise your question in the chat if you feel more comfortable, or you can raise your hand and I will pass the floor. Me and my colleague Daria, we will both moderate the session. So I can see already a first question and another just arrived. So first one, how do clinicians tell the difference between type 1 and type 2? Is there a specific test, as it seems there are similarities? Do the clinicians misdiagnose at times?
Yeah, so that's an important question. So I only touched briefly on the diagnosis because there will one session really focusing on that. But for now, I can say that in type 1 for Willebrand disease, you have a reduction in how much of the protein you have, but the protein functions actually normal. So if you have only, let's say, 30% of the protein in your circulation, then the activity of that protein will also be roughly 30% compared to normal. So the amount of protein and the function of the protein are more or less the same. So we look at the ratio between the activity and the amount of the protein. And if the activity is much lower than the protein, then this is a functional defect, and that's what we call type 2. And when the protein and activity are more or less at the same level, this is what we call type 1. And we have defined some cutoffs for this ratio between activity and protein content. But of course, at this time in the guidelines, this is set to be 0.7. So if you divide the activity by the protein, it should be below 0.7 for a type 2. But of course, this is not a fixed absolute level. It's more or less a guide. It's roughly there. So sometimes it could be that this ratio is 0.72, and then it would fit with a type 1. And then if you measure again in the same patient, it can be 0.68, and it would qualify as a type 2. So it's not an absolute cutoff, but that is more or less the principle by making the distinction between type 1 and type 2. And there are some more specific tests, like doing multimer analysis to try to get this more clear. But the basic idea that there is a discrepancy between activity and how much of the protein you have.
Thank you so much. And we have a question from Olivia, raising her hand.
Yes, hi. Good evening, everyone. First of all, thank you for a great and thorough presentation. I think it's one of the best I've attended because it's very clear, it's very simple for those who really want to be introduced in that topic, and we needed to raise awareness, so thank you. My name is Olivia Romero-Lux. I'm at the steering committee of the EHC, of the European Haemophilia Consortium. I have a question about long-term prophylaxis. You say for hemophilia, it's pretty much when you have a severe phenotype, then you get the long-term prophylaxis whenever it's possible in your country. Why don't von Willebrand patients benefit from the same long-term prophylaxis? Especially, I would say, is it a question of treatment? But I see there are treatments coming in and in the pipeline. Is it a question of availability? Or is it depending on the phenotype? And my last question, of course, would be, and Baiba won't be surprised, what about women with menorrhagia? Is that a very, not that serious bleed, so they don't get long-term prophylaxis if they bleed from menstruation? Because this is really something about quality of life and exhaustion and anemia for women. So that's my last question, but a very important one to me.
Thank you, because it's an important point about the long-term prophylaxis. Actually, you ask, I think, 6 questions in one, but I'll try to tackle them all. So it first depends on phenotype. So there are definitely patients with von Willebrand disease that have limited bleeding. And that bleeding is so limited that it doesn't warrant continuous prophylaxis. But of course, this is a scale, and you get up more and more bleeding depending on your phenotype. And on the end of the most severe, of course, is type 3, and you have also some types 2 that are quite severe. So it first starts with the phenotype. Your bleeding should be severe enough to consider prophylaxis, because if you go on to prophylaxis, that is usually then done by either intermittent use of desmopressin or von Willebrand factor concentrate. And there is becoming more and more awareness that also for Willebrand disease patients may benefit from long-term prophylaxis. So in the most recent guidelines, there is now already a recommendation to suggest long-term prophylaxis in patients with severe and frequent bleedings. That's preferable over on-demand treatment. So more and more patients with type 3 for Willebrand disease with joint bleeds or regular bleeding from menorrhagia or intestinal bleeding, they more and more get prophylaxis. And then in those cases, that is with Willebrand factor concentrate. And then they usually have this 2 times a week or sometimes 3 times a week. But it requires intravenous injections and self-injections. So when your bleeding is not that severe, you may not go into that. But if it's severe enough, it's been done. Then we also have in some type 2 patients problems with intestinal bleedings that also frequently get long-term prophylaxis. But then you move to a phenotype where there's not that type of bleeding, but where menorrhagia becomes very prominent. Even if you have not a very severe form of Willebrand disease, you may have regular problems of heavy menstrual bleeding. And there you could consider not long-term prophylaxis in the sense that you do twice a week intravenous injections to prophylaxis, but it may go that you focus the preventive treatment around the expected menses, the menstruation. And then it really becomes a matter of how severe is the disease? Do you have a type that may respond to DDAVP or not? So if it's responsive to DDAVP, women may start trying to do the contraceptive pill and tranexamic acid, but if that is not enough, they may go into using desmopressin regularly around the heavy menstruation. But it really depends on the phenotype first, and then what would be effective, DDAVP or Willebrand factor concentrate. And then, of course, in the end, I think more women with heavy menstrual bleeding would benefit from these types of treatment that are currently being used. I think we should be more frequently using Willebrand factor specific treatments in women with heavy menstrual bleeding. And then finally, you have your question about access to care. Yeah, that may be different between different regions in the world regarding this. Yeah.
Thank you very much. So I will pick the next question in the chat. Let's start first with compliment. Thank you very much, Baiba, for sharing your experience. And thank you, Professor Eikenboom. You have explained it very well and very clear. Could you tell us what is the best treatment option for Willebrand 3? Prophylaxis, yes or not? And with which product, recombinant, plasma? What new treatment option might work? Any subcutaneous? And for Baiba, what can we do to access a correct diagnosis and treatment? Thank you very much.
Okay, so if I heard correctly, you asked what's the best prophylaxis treatment for a type 3 patient. Was that the question?
Yes.
Okay, so because you don't have any production of Willebrand factor, you will need a concentrate. So you need infusion of concentrate. And actually, all concentrates that are around, either or not, whether they contain factor 8 or not, can be used for prophylaxis in type 3 patients. Because it's not an acute bleeding, it's prophylaxis. So if you infuse a pure Willebrand factor product without factor 8, that's not an issue because your own factor 8 will start rising as soon as you start to infuse Willebrand factor, and that will be enough. But you can also infuse a product that does contain factor 8. It doesn't matter. They will all work fine. So it may depend on your center where you're being treated what they are regularly using, but actually they can all be used equally. But of course, desmopressin cannot be used in type 3 von Willebrand disease. And it's all intravenous at this point. There are no subcutaneous forms of Willebrand factor concentrate. So for type 3, you will need intravenous injection.
Thank you very much. Baiba, there was a question to you. So what can we do to access a correct diagnosis and treatment? Tricky question.
I don't have an answer for that. My road to get my diagnosis was very, very long. And because I have the knowledge from all the conferences, I have been lucky to participate over past, now it's like 20 years, then I was able to ask for the right diagnosis, because before that, I was always told that I have a mild phenotype, it doesn't matter, nothing will happen. And there were some very stressful situations in our family, like there were events in which we thought people could die from bleeds and such. And then so we started, like it was 2008 or 12 when it was first possible in Latvia to do the test, which was about von Willebrand factor activity levels, like not just the level, but how it actually functions. And for my type, it didn't give a clear answer, because the test could not identify anything below 15%. So I was around 7, and it didn't like give us a result. Then a few years later, there was twice initiative when blood from Latvian patients was collected and sent to university clinic in Tartu, because it's like Estonian university which could do the multimer tests. And again, in my case, it didn't bring back a perfect answer. And the only way for me to find out my type was to do genetic testing. And that was possible because I was requesting very, very hard and lobbying and trying to get genetic testing for all people with rare, not only bleeding disorders, but rare diseases in general in Latvia, because that's like a normal standard in Europe, that when you can't find answers, you usually try to get it there. So as I was saying, I was almost 40 when I finally found it out. And I don't think that people in Europe, as since we are all European citizens, and the possibility should be the same. It's not fair if I live in a country which can't go and understand all these nuances about the bleeding disorder, and because of that, I can't access the treatment for the situations when I need it. Because like every time when I go to hospital, it's me who is explaining to doctors what has happened, and that shouldn't be the case. We as patients shouldn't do the doctor's job, right? And that's why I'm so very thankful for Professor Eikenboom for explaining so simply all these things, because every time we hear about coagulation cascade, it's only like people saying like, this is so complex, here is the picture, we won't tell you in detail because this is like too like rocket science and you don't need to know that. But this is the first time in my life when I see all those little knobs and bricks, and I think it's like perfect presentation to explain how it all works, so we as patients can understand better what's in our blood and how to understand our symptoms better. Thank you.
Thank you very much, Baiba. And if I can add something for patient community, but also professional community. So if you face as professional a complex case and you want to share the case with other experts, please contact the ERN, because we perform this kind of interaction between experts. And if you are a patient, you are struggling in getting a proper diagnosis or access to treatment in your country or a proper follow-up and therapy, also please contact us, because I don't want to, of course, to sell fake hopes, but we do our possible, and sometimes we succeed helping. It not 100% of the cases, but we do the possible we can, and it's an additional, how can I say, an additional tool that also patients community, patients organization can share within the scientific and the patients community. Please contact ERN for this kind of difficulties or burdens you can find for both part, health professional for complex case and patients in getting the right diagnosis and treatment plan, or
And I think,
access to treatment, even access to treatment.
and of course, here I need to add that from our side, we are also there always for patients, and the EHC on Willebrand Committee specifically works, of course, to improve access to treatment and to raise awareness for all von Willebrand patients in Europe. And I think everyone has seen our email. We have dedicated the mail for this. It's vwd@ehc.eu. We have support group on WhatsApp for von Willebrand patients. So we are there for you. Just drop us an email. And we have quite a few questions, so I think we need to go through them.
Exactly.
I can read the
I
next
can pick
one.
Bye.
Okay.
Go ahead. Go. Go. Go.
So the question is, do you perform routine analysis on antibody anti-von Willebrand factor?
Well, of course, in hemophilia, we are used to do that because there's a very, especially in hemophilia A, frequent antibodies being formed. In Willebrand disease, formation of antibodies is very rare. And it's actually only being encountered in a minor subset of type 3 Willebrand disease patients. Actually, a recent study on type 3 Willebrand disease showed that only 6% of type 3 patients over many years develop antibodies against Willebrand factor, whereas in all the other types, actually no antibodies occur. So we do not routinely test it and only do testing when there is suspicion on the development of antibodies, because you don't find any effect anymore of your treatment. So we do not do it routinely.
Thank you.
So the next one. So thank you, Baba. I've seen you have shared recommendation. Thank you. You have them in the chat. So a question for Professor Eikenboom. If you have type 2N and your menstruate is treated with prophylaxis, is it not better to start before your menstruation is started with the prophylaxis than when the menstruation is already started?
Yeah. It's a little bit difficult. So type 2N is a strange form of Willebrand disease because then you have a defect in the Willebrand factor causing factor 8 not to bind to Willebrand factor. So actually, most type 2N patients do not have a problem with the binding of the platelets, and really the primary hemostasis is intact, but factor 8 is not stabilized by Willebrand factor. So you get mainly a drop in your factor 8 level, whereas your Willebrand factor level still does its trick for making the platelet plug formation. So actually you need more factor 8, but to get more factor 8, you just have to give Willebrand factor to those patients, because then your own factor 8 again binds to the normal Willebrand factor that's being infused in the patient. So if you are being treated with a Willebrand factor concentrate as prophylactic treatment in a 2N phenotype, then it depends a bit on which concentrate you're being treated with. If you're being treated with a concentrate that also contains factor 8, so then at the moment you infuse Willebrand factor with the factor 8 in the concentrate, your factor 8 is normalized. If you treat with a concentrate that only purely contains Willebrand factor, it will take some time, usually up to the next day, for your factor 8 to start rising. So it depends a bit on which concentrate you use for the prophylaxis, how fast your factor VIII will be corrected in 2N. So you could consider, if you're using let's say the recombinant fulfillment factor concentrate that only contains fulfillment factor, it may take up to the next day for your factor VIII to rise to normal levels. So maybe then it's more advantageous to start a little bit earlier with the prophylaxis. But it's always difficult with the menstrual bleeding to know when it really starts. So it depends on the severity of your symptoms if you take this precaution to start already a little bit earlier. It really may depend on the patient basis, how good you respond to the prophylaxis.
Thank you so much. I will read the next question. I saw a patient with von Willebrand type 3 who suffered from an intracranial bleeding as first bleeding symptom when he was about 6 months old and spent his, okay, it's jumping. The chat is jumping, sorry, and spent his vacation in our area. Should the prophylactic treatment with von Willebrand factor be started right after making the diagnosis von Willebrand disease type 3, even if the child is very young and did not have any severe bleeding before, to prevent an intracranial bleeding?
Yes, of course, the intracranial bleeding is a very severe bleed and it's dramatic when it occurs. But still, it's also, even among severe von Willebrand disease patients, it's a rare bleeding manifestation. So in general, we do not, because then you would need to start all patients on prophylaxis from birth on, which is also a very heavy challenge for small children. So actually we do not do that because the chance of having a intracranial bleed is still very low. So we really, and also even also in severe hemophilia, we don't treat immediately. We also usually wait for the first symptoms of bleeding, or although with the new treatments for hemophilia, we tend to start earlier. But in fact, it's unfortunate that an intracranial bleed occurs, but I don't think it merits the fact that you would start upfront long-term prophylaxis in all type 3 patients. That would be, I think, over-treatment with also major impact on the daily life of the patient.
Thank you very much. I have tackled one question that was for the ERN, so I will just name it quickly also orally. So I was asked how patients can contact the ERN. Thank you for the question, because indeed recently we have launched an info point for patients requesting our assistance. I have put the link in the chat. You can complete the form and we receive the request knowing precisely what you need for, or you can write to me. You have my email also in the chat. And if you cannot find this information in the future, or for people that will watch the video, all what I said, it's on our website. So just EuroBloodNet .eu. Then another question for Professor Eikenboom. So if you have type 2N, which medication will be the best for treatment? I know there is a big difference in treatment for this specific type. Is it depending on the difference in levels? For example, we have been treated with IMATE-P and Willate. Is there a difference in them?
Yes, it really depends on the specific characteristics of your type 2N, because some patients with type 2N have completely normal fulfillment factor function regarding the platelets and only have a low factor VIII, whereas other patients with type 2N may also have a slight reduction in their fulfillment factor level, up to, let's say, 40% fulfillment factor and only 5 or 10% factor VIII. So then they may have also a defect in the platelet plug formation. due to the lower fulfillment factor level. So it really depends on your phenotype. Some patients with 2N still have about 15-20% of factor VIII. Others may have factor VIII levels as low as 5 to 8%. So that really depends on how severe it will be and how your treatment will be. But as I explained in the previous question, when you treat with fulfillment factor, your own factor VIII starts to bind then to the infused fulfillment factor. And it depends on whether you use prophylaxis. When you use prophylaxis, you do not have an immediate need, acute need for high factor VIII, which you need when you have a bleeding. So if you treat a bleeding, you want to have your factor VIII corrected at the time of the bleeding. So then you want to infuse a medication that also contains factor VIII. But for prophylaxis, only fulfillment factor would also be okay because your factor VIII will normalize the days after. So for an acute bleed, I would say you need also a product that contains factor VIII, or you need, if you use a recombinant fulfillment factor that only contains fulfillment factor, you need also to be treated with a factor VIII concentrate at the time of a bleeding. Then the question whether Hem-HP or Wilate differs. Both products contain fulfillment factor as well as factor VIII, so you can be treated with both products. And basically, it usually depends on your center, because most centers will only have Wilate or will only have Hem-HP in their center, because they just choose a product because it's best to have experience with one of those products, because the concentration fulfillment factor and factor VIII in the products is different between Hem-HP and Wilate. So you need to have experience in your center how to dose the specific product. And if you continuously would switch between products, that makes it more difficult for the doctor. So you will experience that in one center you may be treated with Hem-HP, and in another center this can be Wilate, but actually both products can be used with equal success in my experience.
Thank you so much. Do we have any other questions in the audience? Probably. We're about to close the session, of course, because we're running out of time, but just in case, last opportunity for someone.
Yes, and waiting if the very last question arrives. Maybe we can also advertise the next session that will be more or less in 1 month, so the 7th of March, same time, so 5:30 for Brussels time. We are going to talk about genetics of Willebrand disease with Professor Frank Liebeck and Joe Torter. I'm so sorry with the name. I know I say them not in the right way. Thank you, Daria, for assisting me. And I see one question. So the calling the next session has helped. How will we be able to get a certificate of attending the session? You talked about it at the beginning, but I had an issue at the hospital. Yes. So the healthcare professional can request the credit of the EBA for each session. I will contact those people that have participated to the session, explaining the instruction for getting the credits. If you don't need the formal accreditation, but you want just a certificate of attending, which is a different one, please request it writing to me or Daria or both of us. And so we will send you a certificate of attendances. If it's not clear, please tell me and I will provide more information. So I'm reading, thank you so much for this great presentation. Looking forward to the next. Thank you for this warming, encouraging word. Indeed, it has been really a great pleasure to assist to this webinar. It's always difficult to get the proper level of dissemination when it comes to those complex disease and when it comes to also varied audience. So it has been great, and thank you so much for your time, expertise, and your question.
And before we wrap up, I just want to give the last word to Baiba to say probably something from the patients community.
I think this has been a successful first day of our education. I have learned a lot again, and I believe other patients as well. I would invite all patients to join their national member organizations, their yet hemophilia societies, but hopefully in future the name would also say that they include everyone. And just be active and learn as much as you can. And for doctors, the message would be, please participate in all the events that EuroBloodNet is doing, because that's for your education, so you can help us as patients. And also be friendly with your patient organizations, because we often need doctors' help to explain us these complex issues, so we don't ask wrong questions. We are educated and can help ourselves. So I will be happy to see you again next time. And thank you so much. Thank you for the team for organizing this, our committee for putting all this together, and of course, Professor, thank you so much from all my heart.
And I see a lot of
You're
comments.
welcome. Yeah.
Thanks. And I see also a comment from our president who was here listening to the session. So thank you, everyone. And thank you again to the ERN for this brilliant cooperation and for this brilliant program that we are putting together.
It's mutual. It's mutual. Thank you so much again, and see you in a month, more or less. And happy from Willebrand Disease Awareness Day.